right, so it is 12 o'clock. All right, so we have a whole bunch of people who just joined. But I wanted to welcome everyone to today's Psychology Grand Rounds, first of the month. We have the very good fortune of hearing from Dr. Anitha Iyer, who's going to be talking to us about building access to psychological services to promote whole person care and population management. And Dr. Guy Montgomery is going to be moderating the Q&A portion of the Grand Rounds. Want to tell you a little bit about a speaker and moderator first, and then we'll talk about some housekeeping things. But in terms of Dr. Iyer, she's the Director of Behavioral Health Population Management here at Mount Sinai Health Partners, also an Associate Professor of Psychiatry at the Icahn School of Medicine here at Sinai. In her role, she develops necessary pathways, workflows, and programming to improve access to behavioral health assessment and treatment. And through a systematic data-driven approach, she aims to promote better clinical outcomes for patients, streamline evaluation and treatment processes, and optimize provider performance. Prior to joining Sinai, she was the Chief Clinical Officer and Vice President of Crisis and Behavioral Health Technologies for Vibrant Emotional Health, a New York City-based non-for-profit organization, and served as an advisor to the National Suicide Prevention Lifeline. She's a recognized leader in the innovative delivery of crisis services, frequent speaker at behavioral health and suicide prevention conferences across the nation, and has served as a subject matter expert for media engagement on matters pertaining to mental health and suicide prevention. In addition to her current role at Sinai, Dr. Iyer serves as a co-chair of the 988 National Steering Committee and a member of the APA's board for the advancement of psychology in the public interest. She is multilingual and fluent in English, Tamil, and Hindi Urdu, and a licensed clinical psychologist. She earned her Ph.D. in clinical psychology from Columbia and her BA in biology from Barnard, as well as a master's in public health from Hopkins. In terms of Dr. Montgomery is a clinical psychologist whose research training and clinical efforts are focused on improving patients' quality of life associated with cancer and its treatment. And in particular, he's focused on developing and testing mind-body interventions to reduce symptoms and side effects associated with cancer and its treatment. His work recognizes the how we think and how we feel emotionally, how that can have profound effects on how we feel physically as well. Also a prior Grand Round speaker where, talked to this group on those very topics. Dr. Montgomery is professor and vice chair in the Department of Population Health Science and Policy and director of the Center for Behavioral Oncology. He is also the director of psychological services at the Dubin Breast Center, is past president of APA Society for Psychological Hypnosis, and a fellow of APA. He received his PhD in clinical psych from UConn, completed a fellowship at MSKCC, and received postdoc training in health economics at Columbia. Very well published, over 100 peer-reviewed empirical articles, and has received funding from the National Cancer Institute, the National Center for Complementary and Integrative Health, and the American Cancer Society for research and training efforts. So really, brilliant, highly accomplished people, today giving our grand rounds and moderating. So I look forward to a really great learning opportunity and kind of a dialogue after. From a general housekeeping perspective, and then I will turn the tables over to Dr. Iyer. Anyone seeking CE credits for psychology, that link will be posted to the chat. So just keep a lookout for that. Click on it, and it will kind of take you to the form that needs to be completed. And then anyone can change their viewing settings. So we are no longer doing a webinar format. And if you want to see all of the boxes, you can just click gallery view on your end. And if you prefer just to see this in speaker view, just to see Dr. Iyer and the slides, you can just change that to the speaker view. All that being said, Dr. Iyer, it is all yours. So thank you so much for being open to talk to us here at Grand Rounds today.
Thank you so much for having me. I'm so excited to do this. It occurred to me that this is my first time presenting the work that I've done through Mount Sinai Health Partners to the Department of Psychiatry and to our psychology colleagues in particular, and very excited to see some friends here. I just want to call out some colleagues from MSHP who are here. Appreciate your support and collaboration in building some of the programs that I'm going to present today. And also just want to shout out my colleagues from the Behavioral Health Center at Rivington, where it's the best part of my week is the patients I see there. So um, thank you again for this platform. I will quickly take a minute to share my screen. And then I hope Christina, can you confirm that you now see it, the one slide on the
Yep,
screen?
looks great.
Yep. Okay, perfect. So I want to talk today about the work that Mount Sinai Health System does through the space sort of for population health in practice that is Mount Sinai Health Partners. I'll tell you what that is as we're talking. But really, with the goal of building access to psychological services and putting them sort of as a centerpiece, putting psychological services and access to them as a centerpiece to whole person care and population management. So my role, where that fits in, I'll tell you about it as we speak. And really, just as we're thinking and as we're talking today, I'm hoping folks can keep in mind that mental health and substance use services and having access to high quality services in a timely manner is really important to drive a whole host of outcomes for patients, both medically and psychiatrically. And when you think about whole person care, it's really impossible to think about that without thinking about mental health, sort of as a key driver of that. So that's the context in which a lot of this work that I'm going to be presenting today occurs, has been set up, has been implemented and scaled across the system. So to do that, we'll talk first about what value-based care is, which is sort of the framework within which all of this has been built and sits, and why value-based care matters to behavioral health professionals. And then we'll talk a little bit about the specific programs that Mount Sinai Health Partners has built for the system to put forward this behavioral health population management strategy. And then I'm hoping we'll have time to chat and happy to answer any and all questions that folks have about all of this. So the context really starts at the 50,000 foot level when you look at the US healthcare system in comparison to healthcare systems around the world. So this chart shows the US healthcare system and expenditure on healthcare in the United States when compared to other OECD countries. So this is data from CMS. And you can see that the US healthcare spending, which is the US spend line, is the top line that you see on this graph, sort of far and away from other countries with similar economies, which are all kind of clustered below. And in the top line, you can see, I hope, that it has also been steadily rising starting around 1980. But if you look at the numbers on the side, you can see that the US spends about, and as of this data, which was as of 2020, about 18% on average every year on healthcare. Comparatively, other countries are somewhere close to even half of that amount. So that's sort of something to be concerned about because this isn't a sustainable trend for us as Americans. And, this matters to us because it is our economy and our tax funds and so on that are part of this picture. In 2022, CMS estimated that the US healthcare spend was about $4.5 trillion. And it expects that by 2030, the United States will be spending about $6.8 trillion on healthcare. So this is important to us. Why? Right? Because we are part of this ecosystem that is driving this healthcare spend. So this graph essentially represents the first part of trying to understand the ecosystem within which this dynamic is occurring, this dynamic of sort of unfettered healthcare spending without necessarily the best outcomes to show for it, right? We have not necessarily better outcomes in terms of lifespan. We don't have necessarily better outcomes with respect to chronic disease management, certainly don't have better outcomes with respect to access to timely healthcare, and so on and so forth. So that's where this conversation and the shift to talking about things as value-based care starts to emerge. So what is value-based care? So looking at sort of the ecosystem first, when you think about the healthcare system, it's not just the patient and the provider, right? There's the patient, but the patient interacts with a number of entities who all interact with each other. And all of these entities are part of this dynamic of healthcare access, healthcare outcomes, and healthcare spend. So the patient, if we position the patient in the center, you have treatment providers, that's all of us. But you also have social service providers. We know them well, right? Those are the transportation entities, the benefits management folks, the sort of food security people that sort of provide food access and so on. Those are the providers that we interact with, we refer our patients to, and so on. You also have caregivers and social supports. We know them when as well. These are the parents, the spouses, the children that we interact with, foster parents, and so on, that are part of the patient's ecosystem. And then there are payers. Now, those of us on this call who are more on the clinical side of things, we don't exactly engage with payers at an administrative level all the time, but payers are a really big part of the healthcare system, right? When we put on our administrative hats, most of us that have some administrative role know that sort of the interaction with the payers, the negotiation of those contracts, how much money is agreed upon, how much money is paid, what are the denial rates, all of that comes into play with respect to how much access we're able to create for patients and the quality of care that we're able to provide. And so everyone in this structure, including the patients who themselves interact with each of these entities as well, has goals and incentives. Sometimes it's straightforward, sometimes it's a little more complex. Sometimes the goals and incentives of every entity in this equation is complementary, and sometimes it competes. So aligning the these entities on healthcare outcomes is really key to be able to drive toward better value. So this is where my role fits into to this equation, to driving value-based care from a behavioral health standpoint. So I am employed by Mount Sinai Health Partners, which is the population health unit of the health system, where a lot of these value-based care conversations and then subsequent arrangements for value-based care are managed for the system. I'm faculty in psychiatry, but my role was intentionally situated in population health to be able to innovate, implement, and drive value-based care with behavioral health as a centerpiece for the system. So want to get a little bit more into what is value-based care. What does that look like practically? How is it experienced, right? So I mentioned in the previous slide that the goal is to align incentives for the different stakeholders, and we do that through advanced payment models, right? So really what we're trying to drive in driving toward value-based care is driving from a volume-based model, which is really fee for service, to a value-based model, which is really payment that is based on outcomes being met. That's a very simplistic, high-level way of saying that. But volume-based care, we know, right? That it's very much sort of part of our thinking as behavioral health professionals. You see a patient, especially if you think about private practice, you see a patient, you collect a payment for that particular visit, and then on you go, right? If you provide a testing battery, you have a set fee, you charge that fee, you provide the testing, you provide the report. And so for the volume that you got, you got your payment. So it's fee for service. Whereas a value-based model is different. It looks at defining payment on the basis of value. So how this begins and how it gets practically implemented is that rates are negotiated between providers and payers, so the health system and the various insurance companies that we contract with, but also a model is negotiated with them, between them, in a value-based care model. So we collaboratively project a risk-adjusted expense that is associated with an anticipated total cost of care per member per month. So that's a mouthful. What it means is essentially we say that, hey, based on the risk profile of our patients, based on the proportion of our patients that are older, that have diabetes or other chronic disease, that have depression or other chronic mental health conditions or substance use needs, based on sort of a risk adjustment model, and it's the way I'm just defining this is doesn't do justice to the layers that go into risk adjustment. But based on all of this, we anticipate that it will cost us about $1,000. That's a number I'm making up. It'll cost us about $1,000 a month to take care of a patient with this type of risk profile. So based on that, the health system and the provider and the payer agree upon a contracted per member per month rate that they say, okay, we'll give you this much per member per month. So that's the amount that you have to work with as a health system. Now, if the health system and the provider achieve that outcome in less than the projected cost, so we got $1,000 a month, but we got it done in 900, then the health system or the provider can keep the money that we didn't spend as part of our savings. That's where it's called shared savings. Over time, we move into a shared risk model with these contracts. So you start out primarily with a shared savings model, and over time you start to share in the risk, which means that if it cost us $1,100 for that patient rather than 1,000, then we split that $100 with the payer. So we eat some of that cost essentially, and so we're taking on risk. So the expectation when you enter value-based arrangements is that typically that as you settle into the arrangement, you will move toward taking on shared risk so that there is incentive for the provider to try to see the patients in as few visits as you can to keep them healthy, to keep them out of the emergency room, to keep them out of unnecessary hospitalizations, and to really focus on preventive care such that it delivers good quality outcomes for the patients while also driving profit for the health system. This is sort of the antidote, if you will, to that model which you saw in the graph that I showed at first, where healthcare expenses just keep going up. The agreed upon incentive payments, which I mentioned, are also additionally qualified with quality standards being met. So there's a host of quality incentive measures that are identified and agreed upon at the outset. Depression screening rates are actually one of them. And when you hit those quality incentives, you can get some additional performance-based dollars. That's sort of a check to make sure that folks aren't incentivized in a perverse way to provide poorer quality care to drive less care, for more profit kind of model. So you do have to demonstrate that you're providing quality care. So the idea again is that this incentivizes a focus on value and outcomes rather than volume. It also ideally provides collaborative partnerships toward whole person care. Again, going back to that diagram I showed of the multiple stakeholders, in order for a diabetic patient to be managed, in a healthy place, the provider does have to think about do they have access to good meals, regular meals that are healthy, that are, that allow them to make the right choices to manage their A1C and so on. So ideally, it promotes partnerships around care coordinations and partnerships with community-based organizations to provide medically tailored meals or to figure out sort of strategies to get the patient to be able to exercise. If the patient has a comorbid depression, making sure they're going to their mental health visits so that they're not demotivated to take their medications, to go to their, pick up their meds and go to their visits and exercise and eat right and so on and so forth. So the health system at the moment has 5 value-based contracts with various providers. There's a couple more that are under negotiation. And then there are 2 additional ones that are full risk contracts with the Medicare Shared Savings Plan as well as Health First Medicaid and Medicare. When I say full risk, that again, as I said earlier, are where we are responsible for both the risk, which is called downside risk, as well as the savings. So moving on to why this all matters to us as behavioral health providers, it might seem like sort of this faraway thing that is more of a contracting concern. We have other things we think about on a daily basis, but it really is, for me, it has been an eye-opening experience to think about how important the services we provide are in helping the health system drive this movement toward value and toward outcomes for patients. So this graph, I think, it's an old graph. It's from 2020, and it was in a McKinsey analysis. But I think it really sums up what we're talking about here and why we, as behavioral health providers, are so important to this equation. So on the left side, you see the insured population in the United States. And you can see that it's about, on this graph, it says 23%. But year over year, the prevalence of behavioral health diagnoses in the population at large is roughly about 20 to 25%, depending on what data set you look at. 25%, pretty much the standard number for New York State, the federal average. Globally, that number is also pretty standard. It's stayed at that number for a long time, right? So about a quarter of the population has some sort of behavioral health diagnosis. However, when you look at the right side, you can see that that quarter, that 25%, accounts for 60% of healthcare spending, right? And the numbers you see on there are in billions. Um, so 60% of the spend is accounted for by 25% of the population. And further, the light blue box shows you that out of that 60%, 53% are on medical services, right? Only a small minority of that 60% spend by patients with behavioral health diagnoses is on behavioral health services. So this is where it comes full circle, right? This now is the patient that has depression and diabetes, depression and heart disease, and where they're in maybe unmanaged depression or unmanaged behavioral health diagnosis is contributing to their difficulty adequately managing their medical services, medical needs, right? So that's where, again, underscores why this kind of lens is important to us as behavioral health professionals. This graph, just sort of further articulates this point, which is that people with behavioral health conditions have 2 to 6 times higher frequency of co-occurring chronic physical conditions as compared to people without behavioral health conditions. So here you can see the dark, the black bars represent patients with behavioral health diagnoses, and the blue bars represent patients without just the general population as a point of comparison. And the left side, the bars on the left side are patients who are commercially insured, and the bars on the right side are patients who are insured by Medicaid. And then you can see the sort of how many times more likely is the patient with the behavioral health diagnoses to have any one of these diagnoses, right? Hypertension, arthritis, diabetes, chronic kidney disease. And you can see it is always higher when there is a behavioral health diagnosis present, but it is much higher when the patient is a Medicaid patient. So again, that underscores the fact that there are multiple stakeholders, multiple issues at play. And when you introduce social factors, especially being insured by Medicaid, which typically means the patient is poor, you have even more of this intersection between behavioral health, complexities in the patient's life, as well as impact on healthcare spending. And I'm talking about spending because that is the lens through which value-based care looks at this and tries to operationalize solutions. But ultimately, we're also talking about outcomes in every one of those layers. So we tried in 2020, when I started working at Sinai, to basically take in all of these pieces of information. We also looked at spend when there is comorbidity with mental health conditions at Sinai, and we saw the data was very clear that every mental health diagnosis that you introduce increases the healthcare spending sort of exponentially. And so then we designed a strategic plan that identified the types of interventions that we would be able to build and scale across the system, such that we can address these challenges of and the behaviors that drive the healthcare spend, right? Particularly trying to reduce unnecessary visits to the emergency room, as well as unnecessary inpatient admissions that then come from there, by trying to situate programs that would drive better medical outcomes. So this is sort of the goal, the big goal that we designed and then built programs that I'm going to talk to you about sort of to try to meet. So this was our strategic plan. I hope you can see it. Some of the writing may be a little bit tiny. But what has already been implemented is the projects that are defined here as phase 1 projects. The phase 2 projects are still in various stages of discussion or pre-implementation, but we really emphasized looking at the data that we have at the system at large, looking at trends in our data, including behavioral health patients and their ED utilization, as well as spends associated with them. And we saw the same patterns that I noted in that McKinsey chart, that our behavioral health patients do seem to drive significantly higher spend. And then we looked at where are the places where we can drive this impact so it directly can be measurable on our value-based contracts. And we quickly identified that we have to look at our primary care practices and really look at building access from primary care. We also spoke with primary care providers and other specialty care providers, and repeatedly they talked about a few trends, which is we don't have access. We don't know where to refer our patients from primary care to mental health services. We also end up managing a lot of mental health needs in primary care, but we don't know if we're doing it well. A lot of times we feel uncomfortable managing those needs. So we designed the sort of phase one programs to try to meet those needs directly. So I'm going to talk to you first about three programs sort of quickly, and then I'll spend the bulk of my time talking to you about the fourth program, which is the referral access program. Um, so starting first with Mind Matters Echo, and I'm showing them here in the order in which we implemented these programs. Mind Matters Echo, which was launched in May of 2021, really was designed to improve primary care confidence with managing behavioral health conditions. And we started with the absolute understanding that primary care is where mental health is managed more often than not. 80% of antidepressant prescriptions in the United States are written by primary care physicians. So we wanted to embrace that fact and ensure that they have the tools that they need to be able to support patients who are coming in and speaking to them. And also understanding that we're not going to have capacity in our psychiatric services and in our OPCs to be able to see every one of these patients, right? And a lot of them don't need to be seen in an OPC either. So we launched this program in 2021. It is a learning collaborative with case-based consultation as well as a didactic component. That format is very much in keeping with the Project Echo model, which was a model that was designed and developed in the University of New Mexico by a hepatologist to bring access to hepatology consultation to providers in rural parts of the state, where they were finding that patients were dying with liver disease, treatable liver disease, simply because there wasn't access to timely hepatology care. So that model has been replicated with a variety of conditions, including behavioral health. We brought that model to Mount Sinai, and we set up Mind Matters Echo to provide behavioral health related consultations for primary care physicians. Again, as I said before, the aim is to improve confidence among primary care physicians in managing behavioral health conditions in their practice. So since May of 2021, we have conducted 37 sessions. They are generally well attended, and they generally have very strong and positive learner ratings. For the most part, folks rate these as strongly agree, and I'm talking about over 80% of the respondents. And typically in areas such as, this session helped improve outcomes or it increases my competence and so on and so forth. We measure a variety of different sort of responses during our post-session surveys, and they've generally been very strong. The slides and the recordings for these sessions are also available on the Behavioral Health Hub, which I'll show you in a couple of slides. This we make it available so that if physicians want to go back and revisit some topics or listen to something they heard in the consultation later, that they can do that. And they can also, there's also, sort of downloadable content like screeners and such that they're able to then access. I want to note here that we have our next session coming up next week, Tuesday, October 7th at 5:30 with Dr. Tim Brennan. And he's going to be talking about sort of the journey through the addictions journey and what solutions exist for patients and families that are hoping to connect with addictions care. I'll ask my colleague Jade from MSHP's communications team, who's here, to drop into the chat the registration link for Tim's talk. I would highly encourage everyone to attend. You do get CE and CME credits for the session, and it should be a really great talk. So everyone is welcome to attend. The next program we launched in November of 2022 was the primary care behavioral health program. In this program, we identified four primary care clinics with high attribution of those full risk enrolled patients. So I had mentioned earlier that the system is at full risk for Medicare Shared Savings Plan as well as Health First Medicaid. So we looked for four practices that have large panels and have high attribution of full risk patients. We also looked at the data around spend in those practices and found that trend to be true, where behavioral health patients in those practices had much higher spend and primarily on medical services. So with that kind of found, we hired and placed two psychologists across four practices. Notably, the four practices, three of them were FPA practices, and one was an Article 28. So this was a really robust effort to learn all the features of introducing new providers into an FPA primary care practice versus an Article 28, two very different sets of factors that you're working with in those. But we managed to get them to sort of fully embrace these two psychologists operationally, right? There's the clinical adoption, but operationally getting psychologists situated in primary care, it's a pretty hefty lift. But we managed to get it done. I want to give a big shout out to my colleague Nick Yip, who's on the call, who is the manager for this program and really helped make a lot of this happen. Um, so that involved, Epic Build, getting sort of billing codes introduced and making sure that their finance teams were looking at denial rates for the psychologists and pushing back adequately, all of that to really set it up as a solid operation. We also built new interfaces in Epic itself, including a program called Compass Rose, which allowed us to be able to track multiple layers of the volume, right? So we were able to how many patients are coming in, how often, how long are they waiting to be connected with a psychologist, how long is the length of stay. We were able to build reports that alerted the psychologist to a patient that's coming in for a visit in the next week who has not just high PHQ and GAD from last visit, but also high A1C or some other evidence, high blood pressure, uncontrolled chronic disease, so that the psychologist could use data in Epic to be able to get patients to get proactively referred into mental health treatment. And then we built clinical models of care within the primary care clinic, such as group therapy for patients with diabetes to teach them behavioral strategies to manage diabetes and healthy eating and so on and so forth. So it was a really sort of multi-pronged program. Over the course of 2 years of operation, the program billed 1,209 encounters. That's billed encounters. There were obviously many more consultative interactions between the psychologists and the primary care physicians. We also had same-day access built into the psychologist schedule so they could push into the exam room and provide supports and so on. The program, unfortunately, was discontinued in March of 2025. But I'm sharing this here because I know we have numerous integrated mental health programs with really talented staff, most of whom are psychologists across the health system. There's a lot of learnings from this program that I think we could implement to not just better situate mental health in primary care, but to drive improved medical outcomes for patients, as well as to drive revenue, right? Because these are billable encounters. Um, the third program that we launched, we launched a pilot in November of 2023, and then it moved to full adoption in 2024. So this was a program aimed at increasing screening for depression and anxiety in primary care. Now, I mentioned when I was talking about quality incentives that depression screening is a quality incentive in value-based care reporting. So annual screening for depression is an expectation and certainly in primary care. But, how often patients are screened, how well they're screened, those are sort of variables that we noticed kind of varied quite significantly between practices. So we decided to leverage MyChart and its capabilities for pushing out screening ahead of an upcoming visit. And to do that, to obviously increase screening rates, but also to gather better data. And our hypothesis here was that patients will provide more honest responses during self-report. It takes out the expectation for clinicians to do that during the visit, so it reduces their burden a little bit. And also, we thought that, the quality of the data, the information you get ahead of the visit, it brings the patient in thinking about their depression, their anxiety, any mental health symptoms that they are experiencing, and perhaps makes them more willing to discuss that with their primary care physician. So what we did, and this was a long 2-year project just to get it built and ready for pilot stage, which was that we had the screeners. We had to take there were about 20 plus flow sheets for PHQ. We had to streamline that to pick just one. And now the system has only one PHQ flow sheet. We did the same for the GAD. And then we folded it into various dissemination protocol and frameworks that exist in Epic. So we looked at health maintenance topics. A big shout out here to the Mount Sinai Health Partners quality team who really helped conceptualize this idea that we can leverage health maintenance topics, which basically alert the system that a patient is due for some sort of health maintenance action. And that includes depression screening, meaning, hey, this patient is due for depression screening. So we leverage that and built in alerting to tell the system this patient that has a depression screening in a due status, due, overdue, due soon status, is coming up. They need to be screened and they have an upcoming visit. So when that coincides, push out the MyChart questionnaire, give the patient, along with the e-check-in that they get about 3 days in advance, send this out, give the patient the opportunity to complete the screener. It does everything you'd want it to. It cascades, it shows the patient the PHQ-2, and then based on their responses, cascades the next questions and so on. Very cool. More importantly, we built workflows that pull this data right into associated flow sheets in Epic so that the clinician can see the patient's responses when they're in the visit and they're not now asking the patient the same questions the patient's already responded to. And we set up alerting so they can't miss it and so on and so forth. So between October of 24, when this started to become adopted at scale by the system, and early this week, so September 29th, we had about 6,000 completed PHQs and a little more than that, 6,100 roughly completed GADs by patients ahead of an upcoming visit. The average PHQ-2 score was a 0.64, and you can see that that is higher than PHQ-2s that were administered in the office. The average GAD score was about a 0.9, again, higher than when the GAD is administered in the office. And the average GAD-7 score was a 12.1, again, higher significantly than when the GAD-7 is administered in the office, right? So two takeaways from this. One, when you send these screeners out, patients do complete them. It can be an effective way to reduce burden on primary care staff while gathering better data. And patients seem to report more positive screening responses than on their own when we ask them those same questions in the office. Notably, the GAD-7, that's a positive average score, which is striking. So as of today, 17 practices across 22 departments, 17 primary care practices across 22 departments have opted in to this approach. Implementation is ongoing as practices are told about this and they are interested in adopting this. There's a pathway for them to be able to get these services provided to them by DTP to get it put into their workflows. Okay, so I'm going to move a little bit faster through this. This is the largest program because I want to be mindful of time and make sure we have time for questions. So this last program is the Referral Access Program. We launched this in July of 2021. This by far is the largest program that falls under my purview. The goal here is to increase access to timely behavioral health care for patients in primary care. We followed what the literature tells us. We know that the patients who have a liaison to walk them through the referral process tend to connect with treatment outcomes much better than patients who have to do this on their own. So what we did was we gave the PCPs an easy button. We basically said, if your practice has a social worker embedded on your payroll, we'll train them on these resources. If you don't, Mount Sinai Health Partners has a care management unit who takes adult patients and sort of helps them through the process. So we worked with the care management team to train them. And essentially, the PCP makes the referral. The social worker or the care manager calls the patient, verifies that the patient wants the referral, explains what to expect, then tries to get the patient an appointment in one of our OPCs at Sinai. And when we don't have capacity, which happens from time to time, we built a trusted behavioral health external network, which will always take our patients. And that trusted network is a small but very carefully curated network. We evaluate every network partner against a standard set of criteria. And then, ensure that they will actually connect our patients because we will track connections. We meet with them every 2 weeks to a month. We look at patient level data to ensure they are actually connecting our patients and that they're coming through with sort of their informal service level expectation that they point us to. So I will say that this program, as of today, has been scaled across all adult primary care at Mount Sinai, as well as all Geri primary care. And before the end of this year, we hope to scale it through the PEDS network of primary care practices as well. I will also say that providers are able to refer into this program in a payer agnostic manner because our network, the trusted behavioral health network that we've built outside, is equipped to support patients who are commercially insured, all plans, as well as Medicare and Medicaid. So it was really important to us to not build a segregated network which only supports commercially insured patients. This is sort of high-level data for this program for the last 3 years. I will just say, just sort of pointing out some key trends, you can see that volume into the program has steadily increased, right? We started with about 1,000 referrals in 2022. That's partial data for 2022 because our data source switched mid-year. But you can see that by 2024, we are over 3,000 referrals. We're, as of today, tracking at about 2,300 referrals for 2025. You can see that our overall connectivity rates, which is how many of the patients that were referred into our network were connected with an actual appointment. We track that and we report that. So you see the overall connectivity rate has trended upward as well. We're at about 61% in 2025. Similar numbers for 2024, sorry, was 61% and similar numbers for 2025. Our Sinai connectivity rate, you can see, has improved over the years, and our non-Sinai connectivity rate has also improved over the 3 years. We do better connecting patients outside of Sinai than we do at Sinai. I'm sure that's something we can continue to improve upon. We did build dashboards. Now, the numbers inside of these images are hard to see, and that's okay. My intent is not for you to look at the numbers. I just want to show you that we are using Tableau to be able to track trends, right? So this picture you're looking at shows us month over month volume that's coming in from each of the practices that are part of this. Actually, now all of Mount Sinai Primary Care is referring into this program, but we can filter, we can click on these. These are interactive dashboards. You're not seeing the interactivity because it's a picture, but we've built it so we can quickly tell any practice, hey, 85th Street, this was your volume trend for this year, month over month, and so on. We've also built it to track connectivity by the receiving facility. Again, the numbers are really tiny. It's probably hard to read, but we note every partner that we are referring to. We don't spell out the Sinai ones just yet, but we can do that in the future. And we look at, as a heat map, how is the connectivity? That way, looking at it, if we see a lot of greens, we know this partner is doing a good job connecting our patients fairly well. The reds are not, they're not doing so well. And that prompts conversations when we have our bi-monthly or bi-weekly or monthly meetings with them. This is sort of a passion area for me. We built another sheet to the dashboard. A big shout out to the Mount Sinai Health Partners analytics team, especially Kritika and Ajay, who did a lot of work on this. They built a way for us to be able to track referral volume and connectivity by race as well as by payer and the intersection of race and payer. And again, hard to see the numbers in here, but essentially, a quick glance on this, again, it's a heat map, right? So darker colors, reds and the oranges are not that good. That means we're not doing so well connecting those patients. Connectivity is represented by the colors. And we're doing a better job connecting a patient, that box is going to show up as green or some shade of green. But the key takeaways, and we did some analysis with this data to look at if there was a statistically significant difference in whether we do a better job connecting white patients versus Black and Latino patients or Medicaid patients versus commercially insured patients. We didn't find statistically significant differences, but the heat map does show us sub-threshold trends. Because when we look at the connectivity rates for Black and Latino patients versus white patients, there are more orange and red colors for the Black and Latino patients than there are for the white patients. The big thing that was sort of striking to me was that we see a much higher volume coming into the program of white commercially insured patients. So there's a number of factors for that. We haven't dived into it yet too much, but it is sort of notable that the bulk of the referrals that are coming in, bulk of the patients that are getting referred for mental health care from primary care are white and commercially insured. We also see a slightly lower connectivity among Latino patients who are insured with Medicare, which we think might have to do with language access. But again, we don't know that for sure. These are just very preliminary trends that we've started to pick up. Couple of things finally before I turn it over to Guy. We have a behavioral health resource hub that the Mount Sinai Health Partners communications team has built. I've included the URL here. I encourage you to take a look. It's a really easy to navigate resource with fantastic content that Jade, who's on this call, has curated. Huge shout out to her. And there are downloadable resources here as well that you might find helpful. We built this primarily for primary care, but I think there are some content here that could be helpful for folks in psychiatry as well. I do want to tell you that coming soon, we have a searchable web-based database of that trusted behavioral health network that will be available to everyone, not just to primary care. My hope is that you can go on there and quickly find your way to how to refer to external behavioral health partners that we know provide good services to our patients. Couple final things. We built flyers for exam rooms to encourage physicians in primary care to refer to this program, making it easy for them to know how to refer. We also built a couple of smart phrases that physicians can pop into the after visit summary, the AVS, following visits, which allows patients who say, hey, I don't need you to make a referral for me. I can find these resources on my own. This way, we hope they're giving patients trusted resources from our trusted network rather than, Psychology Today, which isn't, in my opinion, very helpful. This way, at least, we're driving patients to the places that we know will actually see them quickly. And then we also built, designed and developed postcards that can be placed in primary care waiting rooms. You see on the left, it's in English. On the right, it's in Spanish. We are currently working on content for older adults as well as for kids for their waiting rooms. The hope here is that even if the PCP forgets to ask the patient about their mental health condition, we've told the patient, your PCP wants to know about your mental health needs and can connect you with resources. We hope this promotes utilization of this resource. So a couple of key takeaways, and then I'll turn it over. Sorry, I'm about 3 minutes over my time, Guy. Uh, Healthcare costs are steadily increasing and are heading toward the untenable. And access to behavioral health is really key to driving high value services for patients. That, by the way, means that we as behavioral health providers really need to know the value we bring to the service delivery system, and we need to know where the seats at the table are to be able to participate in these conversations. And that it is our responsibility as behavioral health providers to develop and sustain programming that promotes timely access to high quality behavioral health treatment because it is a key driver of population management. I've included my contact information. I'm happy to send these slides out after, happy for folks to reach out. I also included in the appendix more detail on those 3 programs that I sort of breezed through. All right, I will stop sharing and turn it over to Guy.
Thank you, Dr. Iyer. I want to thank you for a wonderful talk. I might recommend if you do want people to reach out to you, if you could put your email in the chat, and then that's where they'll reach out for any questions or resources from you. So I want to again reintroduce Dr. Guy Montgomery, who's going to be moderating this talk.
All right. First, let me say fantastic. That was such a great description of a great program and body of work. It makes me excited and to see all that's happening, and so impressed. And I'm sure everyone else here on the call feels the same way. So I just want to get that out of the way. All right, and so I think people probably less want to hear what I have to say specifically, and more, and let's get to some of the questions, I think. So I just want to start with a couple of things, and some people have very similar thoughts to what I did. One is from, I apologize if I mess up people's names, Paul Moglia. For the Primary Care Behavioral Health Project, was it determined that it didn't have enough value added impact to be discontinued, or was there some other reason that you had
Uh,
to curtail that one?
some other reason is the short answer.
All right.
We know the health system had some financial challenges. Over the last year. So in the scheme of things, it was not continued. I don't think I will add the primary care leadership in the practices where these two psychologists were disappointed to see the program go because they definitely found for their patients and for their colleagues, having a psychologist embedded in the primary care practice was a tremendous value add. Our time to see the psychologist in the programs was less than 2 weeks always. And because you have same day access, the patient often walks out feeling like they saw the therapist that same day. It's a tremendous value add, but unfortunately, it just wasn't. Well, it was determined that it wasn't financially sustainable.
Thank
No,
you.
and and I would say it's tough. I'm just going to jump on that. Did you have something you wanted to say first, Paul?
No, just thank you for the answer.
Oh, awesome. And I would like to add, I've had a sort of similar experience in that I did a study a while ago on that was essentially hypnosis to control side effects of breast cancer surgery. And we included a cost effectiveness analysis, and on average, it saved the institution about $772 a patient, right? And so, and it, but basically everyone said, oh, like when I do talk to people, oh, so Mount Sinai must be doing that all the time now. No, because even if you do, like even in that case where you do show cost savings, it doesn't exactly wind up in somebody's pocket,
Right.
right? And so, or a departmental budget or whatever, at least, especially not in the short term when you have to hire people to be there to do that, which everybody seems like is afraid to do. So I commiserate with you on that issue. Okay.
I will say, Guy, on that, I think when you put that dollar amount in the context of what a typical per member per month rate is, it's not a small number. So maybe you
No.
weren't talking to the right. I think the VBC folks might be very interested in that data.
Oh, that'd be terrific. Yeah, we calculated that if you could pay the psychologist, you guys will like to hear this, up to about 1.7 million annually, and then you'd break even. So anything you paid them less than 1.7 million, the institution would come out ahead. Yeah, sure, I'd love to. Okay, from Lisa Cohen, is there data on impact of collaborative medical psychiatric care on the volume of medical visits? And I think that's what you were talking about at the end of
Yeah.
the talk.
Yeah, there is, Lisa, thank you for the question. There is, there's a variety of ways in which this data has been sliced when you look at sort of globally, data from all over the world. Most of the time, what they find is, and this is an oversimplified answer, but most of the time, what they find is that access to timely outpatient mental health care reduces emergency room utilization. And when you look at patients with high volume visits, a lot of those visits tend to happen in the emergency room. There's also some data that shows improved DALYs and improved QALYs for folks that report based on health econ type measures. So there is some association in the literature that's established that we looked at, in kind of building our own programs as well.
Oh, great question. Um, Next one, so I want to make sure that I try to get to all of these. Um, Ava Johnson says, "What a great session," and asks for the patient with the comorbidities. I have to admit, I was thinking this one also. Is there any data around how often the comorbidities are like caused or exacerbated by behavioral health, or behavioral health are contributing to the comorbidities? We can
Yeah.
think about you raised diabetes, for example.
Yeah.
long-term lifestyle of not, doing the right things can lead to type 2 diabetes, essentially.
Yeah.
So you can see things going the other way.
Yeah. And we know that sort of other having chronic medical conditions can also then in turn cause patient, right? So it goes in both directions, right? So
Yeah.
including obviously thyroid and such, but also, if you have had a surgery following a chronic, condition that you didn't take care of, and now that's impacting your ability to connect with your friends and isolating you or so on, that can then lead to feelings of depression, and you can go on from there. It can be the circular pattern. I think causality, as I see it, is almost less important than the fact that a correlation exists and it is sizable and that it has impact on patients, both quality of life, clinical outcomes, both psychiatric and medical, and on health spend. So it's an important association to know well.
And it's quite common in my work with cancer patients where you get a very poor prognosis, associated with your cancer. You're likely to feel depressed about that. And yeah, and in many ways, I agree with that. In that, it's sometimes the exact cause doesn't matter for us to have a behavioral health intervention that's effective, useful, and improves patients' quality of life. Okay. I think you covered this. 'Cause the question was, can you speak to the efforts to build the VBC into pediatrics? And
Yeah.
you spoke up quite a bit about that.
Yeah.
That's one of your next steps.
Yeah, for the referral access program, I will just say for screening, we currently have only the PHQ-9 built out. We don't have the adolescent version built out to send. And I know for younger kids, obviously the screening requirements are different, but the PEDS leadership have been quite keen on operationalizing pre-visit screening
Right. All
for
right. And
kids.
then we just have a couple of minutes left. And I had a couple of like larger scale thoughts that may or may not make sense, but I'll go for it. And one is often with this kind of work, especially when it edges into the prevention area, I wonder about the differences between patients on Medicare, like as far as outcomes and cost savings or cost effectiveness, and patients on Medicaid, Medicare versus maybe probably younger, private insured people. And the work you do, for example, maybe that's centered on prevention of future outcomes. Company A, Aetna may pay for that, as
Yeah.
$1,000 a month for a patient, but it might be United Healthcare that reaps the benefit down the road or even just next year. And do you have any thoughts about that, and how that might be navigated?
As in the initiatives that we are building happens to impact patients from certain insurance companies this year, so the other one doesn't see its
Right.
benefit. Is that what you mean?
Yeah. So you sign up the patient in the program. The first payer is paying you 1,000 a month, the
Yeah.
hypothetical 1,000, but then they change to United Healthcare next year.
Right. Yeah, I know that sometimes I'm not, super knowledgeable about those sorts of dynamics in our VBC models and our VBC
Right.
contracts when patients change their insurance. So I just take what I say with a grain of salt. I do know that from our side as a provider system, we are focused on the current attribution that we have and who is enrolled in a value-based contract and who's not.
Right.
Um, and our aim is to provide systems and build programming that supports driving those goals around value that I talked about with our current attribution. It may not be the same patient the next year, and we may be
Right.
working with a different list. We tend, at least for the purposes of the behavioral health programs, we've tried to not think about it on those terms and just focus on what are we
Who's
doing
in,
for the patient. The
who's in
savings
front
will
of you?
work themselves out, and
Yeah.
that's a good thing. The other thing is we've also tried very hard to build programs that don't just apply to VBC contracts. That because providers they can't think about, am I referring this patient is because they are a VBC? What's the insurance? We want providers to be able to refer patients regardless of payer, just focused on the patient's needs, and then let the contracting stuff sort of work out on the back end because our programs were designed to meet those
Right.
goals. If
All
I
right.
hope that
So
makes sense.
that's like future work.
Yeah.
And I think I probably have like 30 seconds left. I'll suggest some future work. Yeah, someone just wrote wonderful presentation. Thank you. Yes, wonderful. Um, Mount Sinai has a lot of clinics now. Have you thought about like rolling out the program in one clinic but not another? And then, doing a comparison,
Yeah.
or rolling it out in three and not in three, and seeing how things work out in regard to, both the clinical outcomes, but also the cost effectiveness analysis.
Yeah, that was our goal with the primary care behavioral health program because we were only in 4 practices. We had other comparison practices, and so on. Obviously, the program wasn't around for long enough to be able to do those sorts of analyses. We are thinking about how to bring access to this referral access network to our
Right.
site clinics. That is something I'm keen on doing because we need places to send our patients when they're ready for discharge from our psychiatric clinic so we can create more capacity. But that's sort of ongoing.
All right.
We'll
Well,
get there when eventually.
definitely fantastic. Thank you so much, Dr. Iyer. Thank you, everybody, for your questions and comments. It's really appreciated. Now, go get those CEs and make sure you don't forget to do that. Thank you very much. Really appreciate it.
Thank you.
Thank you. I want to just echo what you're saying, Dr. Montgomery. Thank you, Dr. Iyer, for a wonderful talk, and Dr. Montgomery for moderating. Thank you all for joining. Yes, do click on your link if you want your CE credits. Join us back here at Psychology Grand Rounds again. November 7th is the next one. So see everyone then.
Same bat time, same bat station.
That's right.